Community component involves 6 monthly home-based HIV testing, while the clinical component is for the treatment of HIV-infected individuals. The control arm, the treatment threshold is according to South African guidelines, while in the intervention arm, every HIV-positive individual is eligible for treatment regardless of CD4 count. Okay, this slide shows the trial setting. To the left is shows the shows the Klabisa sub-district, which is about 3 hours drive north of Durban and is home to about 220,000 Zulu-speaking people. The HIV prevalence is estimated at 24%. And to your right is a blow-up map of the sub-district showing the Africa Center demographic surveillance area in the southern part, and just adjacent to it to the north are the TasP trial clusters. And the color code represents the different years in which the clusters were implemented. In pink, the 4 clusters in pink were first implemented in 2012, followed by the 6 clusters in yellow implemented in 2013, and the clusters in blue will be implemented next month, those additional 12 clusters. Okay, STD-SIM was used to, the STD-SIM model was used to estimate the potential impact of the intervention, and previous work done in the area showed that this model accurately captures the demographic, behavioral, and epidemiological characteristics of the local epidemics, and this table summarizes the assumptions and parameters used to calibrate the model. We assumed a 90% decrease in infectiousness due to ART, 10% contamination rate, and for HIV testing uptake, we assumed that 90% of people registered will be offered the test, of whom 80% are expected to accept it, and 70% of those testing positive will be linked to care. We assumed an HIV prevalence of 24% at the end of 2011, and this was derived from the adjacent Africa Center demographic surveillance area. And the HIV incidence was about 2.4 per 100 person years. So using these parameters, this model showed that it was possible to achieve a 30% reduction in incidence over the duration of the trial. And so bearing the amount of incidence or cumulative incidence achievable over this period, we computed the sample size required to show this, and it was shown that 22 clusters with about 1,000 individuals per cluster would have an 80% power to show that difference in incidence. The average incidence in the control arm was estimated at 2.25 over the duration of the trial, and the 34% decrease will be expecting 1.49 incidence of 1.49 per 100 person years in the intervention arm. We assumed a loss to follow-up rate of 20% both in the HIV negative and HIV positive participants. Okay, I'll summarize the fieldwork procedures very briefly. Fieldwork is carried out by trained HIV counselors. When field workers arrive at the homestead, they obtain verbal permission from the head of the household to enter the homestead. And with the help of the head of the household, they enumerate all eligible members of the household. And then the household head is also asked to complete a household asset questionnaire. A private space is identified in the household, and individuals are consented separately for the study procedure. They are asked to complete a study questionnaire, give dry blood spots, and offered rapid HIV testing. Those testing positive or those who identify themselves as known positive are referred to the trial clinic for further management, while those testing negative are followed up in the next HIV survey round. Okay, so to the left is a map, is a satellite image showing the map of the TasP, the TasP clusters, and as you can see, in 1999, as part of the establishment of the Africa Center, all the homesteads in the sub-district were mapped, and each homestead was assigned a bounded structure identity number. And just before the trial was implemented, the mapping exercise was repeated to cater for newly constructed homesteads. So field workers then carry netbooks equipped with softwares developed within the Africa Center, and these netbooks also have GPS functionality, and that allows the field worker to locate the homesteads. So I'll summarize the clinic procedures. Okay, currently we have 10 clusters implemented, and each cluster has a trial clinic. And participants identified as HIV positive are encouraged to use the trial clinics, while those already established on antiretroviral therapy have the option of continuing with their current provider or transferring their care to the to the trial clinic. And the Africa Center maintains a database of all participants who are taking antiretroviral therapy in the sub-district through their partnership with the Department of Health. And we have ethics approval to link the TasP database and the treatment program database to have a comprehensive picture of people established on antiretroviral therapy or who initiate ART. So I'll finish by summarizing some of the challenges we've experienced during these last 2 years. Okay, so when the field workers, or as I mentioned earlier, to be eligible for this study, you have to be a resident member of the household. But the household head determines membership of the household, while the field worker determines residency. And we define residency as spending up to about 4 nights a week. And with this definition, we found out that young men were less likely to be contacted, even with multiple visits, including a weekend. And we wondered whether the problem was with a definition of residency or if they were truly difficult to contact. And from Helen's presentation, it does appear to be the case. And then that begs the question whether we are missing those that are most at risk of HIV acquisition/transmission if we are not capturing them to offer them testing. We also have to deal with the impact of migration in and out of trial areas. Some members of the community don't work outside the trial areas and only go home during the weekends. And based on our definition of residency, they are not eligible for inclusion in the study. And so another question is, how far should we go in trying to chase those considered to be non-contacts? There's also delayed linkage to care. As you can imagine, home-based testing identifies people earlier in the course of their HIV infection, and the majority of them are asymptomatic. So convincing them to go to the clinic is quite an uphill task. Median CD4 count at presentation to the trial is about 400 cells per millimeter cube, and at presentation to the government clinic is about 317. So you can see that we're identifying people earlier in the course of their infection. And there's also the potential for stigma because these clinics only cater for HIV positive individuals. So if you go to the clinic, the community knows you're positive. Okay, so we are seeing high numbers of people with advanced HIV disease amongst those known to be positive, and a significant number of them have defaulted on ART for many years, and it's quite difficult to understand why they haven't gone back to their local clinics. They could be worried or afraid of being reprimanded. And about 15% of participants on ART in the government program who transfer their care to the clinic have virological failure at the baseline clinic visit. And genotypic resistance showed that 89% of them have at least one resistant mutation and have been failing for nearly 2 years. And this has implication for transmitted resistance. And Andrew Phillips and his group in the UK showed that with increasing ART coverage, the number of people with new infections that are likely to harbor resistant virus will increase. And this makes us wonder whether transmitted resistance will be present in a form and prevalence that will make elimination of HIV difficult. And this trial is being implemented in an area of South Africa that's the poorest in the whole country, and often sick people are unable to afford transport costs to go to hospital after referral, and this impacts on avoidable mortality. And then I also talk about mentioned contamination. The map I showed you earlier showed that the clusters are contiguous to each other, and so it's difficult to prevent sexual mixing between participants in intervention and control clusters. But a study in the DSA, in the demographic surveillance, showed that 67% of participants have partners within the same local community. And this is further supported by the striking evidence between local HIV prevalence and the risk of HIV acquisition. But our model allowed for 10% contamination. So finally, I'll finish by saying policy may also overtake research evidence, but it does appear that that bullet point is outdated following Helen's presentation saying Zambia has now implemented the new WHO guidelines, and that's probably likely to happen before the TasP trial in South Africa, before the TasP trial is concluded. Thank you for your attention.